All right. Well, let's go ahead and get started, and away we shall go. So, hello, everyone, and welcome to the very first episode of Let's Talk, a webcast where I will be having conversations with people I find extremely interesting about professionally what they're up to, how it relates to current events. I am Dr. Aaron Weiner. I'm a licensed clinical psychologist, and I'm passionate about connecting people with the information that they need in order to make the best decisions professionally, personally, about their health. And so for me, this is just something I'm extremely excited about, to be able to have conversations with people who know exactly what they're talking about and want to share it with you. Throughout the broadcast today, please feel free to ask questions in the comment area, and we will get to them as soon as we can. So that being said, our guest for today is Dr. Mark Gomez. He is a board-certified internal medicine physician, very good friend of mine. I met Dr. Gomez, or Dr. G, as his friends and enemies probably call him. Probably about, let me pull up his video now. I met him a few years back. We were working together on the opioid epidemic at Edward Elmhurst Health. He is the host, or the previous host, of To Your Health with Dr. G. He has a new show that's about to launch. I'll let him talk a little bit about that. But Dr. G, Mark, welcome.
Hey, how you doing? Good seeing you, Aaron. Thanks for having me on your show today.
Yeah, well, can you tell us a little bit about your new show and where people can find more information, what it's going to be like?
Absolutely. Well, I'm so excited to be here to talk health, to talk opportunity, to talk engagement on pertinent topics. And so I'm excited to talk with you. We're going to have a great time. Thank you for the great introduction. My name is Dr. Mark Gomez. I'm a board-certified internal medicine physician. I practice at Edward Hospital in Naperville, Illinois. I'm also the host of a brand new show coming next month, Health 360 with Dr. G. And really that show is about connecting you. It's about you making sure that you have all the tools, the resources to do as best as you can to live happy, healthy, productive, and fulfilling lives. So I'm excited to bring that back. And I was so excited that Aaron, you and I had collaborated together on my previous show, To Your Health with Dr. G, on so many occasions. And I thank you again for inviting me on your show now to talk opportunity. So I congratulate you for taking a leap of faith and continue to broadcast a message, because we have to set the record straight. And it takes healthcare leaders like you, like me, to really engage the public on the opportunities and to face the challenges that lie ahead.
Yeah, absolutely. With information, you can make choices that matter. So for folks, if you're interested in seeing some of his back episodes, it's toyourhealthwithdrg.com, and everything's up there. Fantastic treasure trove of information. Mark's has been welcoming enough to have me on the show a couple of times, but there's, I think, 91 episodes.
Yeah, 93 episodes, and I'll give you the a much easier link, just www.drmarkgomez.com. You'll find everything right there on my old To Your Health with Dr. G. Awesome videos. It's like a cornucopia of amazing information to help you and your family do the best and make sure that you have all the tools for success. The new podcast, the website is www.health360podcast.com.
Marvelous.
All right.
I will be listening. But for today, what we'd like to talk a bit about are your specialty, internal medicine, how it relates to current events, and then how it intersects with mental health. Because, as a psychologist and as an addictionologist personally, we'll be touching on addiction a little bit today as well. But I'd like to start with the topic that's on everybody's mind right now, which is COVID and the COVID vaccine. And I think, there's a lot of opinions, there's a lot of uncertainty, there's a lot of fear, and as humans, we are hardwired to notice when something is dangerous, because that's it's an evolutionary mechanism that helps keep us alive. We look for danger, we focus in on it, whether or not it's a virus or potentially even now a vaccine. So I'd like to start with just a question of one, just truth, facts. Is this vaccine safe? Should people be worried about taking it for any reason?
Wonderful. So you hit the head on the nail. This topic of the COVID-19 vaccine is the hottest topic, hands down, right now in public health and medicine. It's dominating the conversations without a doubt, because we've been up against the biggest public health threat of our lifetimes. So it's taken a global effort to really collaborate and develop this vaccine. First and foremost, this vaccine is safe. There's no other way I can say it, but it is safe. The data is robust. People are talking about the speed. Why was this made so fast? Well, we've never been faced with such an enemy at this point in our lives. And so just imagine the foundation. If we attacked every health problem with this kind of vigor that we've assessed, that we've done during this COVID pandemic, imagine how better the world will be, how many more problems we can solve, and how many more lives we can restore. But the scourge of this virus has been a catalyst to come up with solutions. And the best solution to get out of this game right now, is the vaccine. Make no mistake, the reason why the number of deaths is not higher is because we've locked down lots of things. We've had public health buy-in and initiatives by the scientists and the public health officials to mitigate as much as we can. If we didn't do those kind of things, the numbers would be astronomical, and they're already horribly bad right now. Yeah. Now we have an opportunity to go right ahead. And the best endorsement that I can say about the COVID-19 vaccine is I personally received my first shot last week on Thursday. I'm set for my second vaccine on January 7th. All I had was mild discomfort at my deltoid muscle, right where the injection site. I had it for less than 48 hours. And I tell you what, Aaron, I haven't exercised after I got my vaccine because I had to. But you can check it out on social media. I mean, the biggest advocates are people like me and you, Aaron, to tell people that it is safe and that this is the fastest way to restore normalcy.
So this has not gone in, it has not altered your DNA, you have not grown a sixth finger, you have not had bizarre spasms racking your body. It was just like any other shot.
Yeah, it was just like any other shot I've had. And yes, last I checked, I didn't have an extra tail. That'd be kind of weird in some science fiction stuff. My arm did not fall off, did not detach itself from the ligament attachments and bony attachments to my shoulder joint. No, this is just like every other vaccine that you've had. The great thing of this is why vaccines represent one of the greatest public health initiatives that we've ever had in our lifetime, certainly, because here's what you do: you trick the virus, you trick the infection. You tell your body, hey, I'm going to act like I'm going to give you an infection, but I'm not giving you an infection. And by the way, this is an RNA vaccine. This is not a live virus or kill virus. This is a simple genetic code that will allow the body to trick itself into recognizing, to build antibodies to, in the case that you come up against the novel coronavirus. Make no mistake, tens of millions of us in this country, still have not seen this virus. If you look at the numbers right now, almost about 18 million confirmed cases. And the real number is probably higher because we didn't have testing capacity at the beginning of the pandemic. But again, we're a country of 300 plus million people, 320 million people or so. There's only a fraction of us that have probably seen this virus. So again, the vaccine is our single most important way to get out of this pandemic.
Yeah, absolutely. I think part of it, when you talk about the skepticism, I think what we're seeing here is that there's been a mistrust, I think, in institutions and in information that's been building for a while. And so what happens then is, I think when you encounter something that confirms that belief, confirmation bias is the term we have for this. You get information like, oh, it came so quickly, or, oh, it was supposed to take 18 months and it's been 10 or 11. Immediately your mind goes to this idea of, well, there must be some sinister reason behind this, or there must be some secondary motive or some explanation other than just pragmatism, other than people banding together, working, getting the job done, and it being, a miracle of modern science, essentially, that we're able to do this in a safe way now. But you're saying that's really that's the bottom line, is that there's a lot of very smart people working overtime and they got the job done.
Yeah, they did. Within days of isolating the genetic sequence of the virus itself, the prototype for a vaccine was already there. The amount of technological advances that we've made just in the last decade have been profound. Computation, collaborative bioengineering. And so these are the breakthroughs that we've needed. It sounds like it's out of a science fiction movie, but I guarantee you, this is real life.
Yeah. Well, so say you've got, and if you've encountered this would be magnificent to talk about it. If not, I'd love to hear your take on this. Say you've got a patient, someone you're seeing in your practice who's on the fence about this. Maybe they've heard some alternative information, maybe anything new. They're just kind of resistant to change. Have you had any interactions where you've been able to present a case that's worked, that's helped move them towards making a change, taking that action? What's been helpful? Because I think, perhaps there's medical professionals watching, but even just for us thinking about family members, if there's certain members of the family who have been looking at COVID differently, approaching it differently, who might be hesitant to get the vaccine, I think it could be really helpful for us to know what strategies you use to get people to take that leap if it feels like a leap.
You hit the head on the nail, and this is where trust is the biggest thing. There's no doubt that people trust their doctor, and so that you have that relationship with your patients, and I have an amazing relationship with all the patients that I'm very fortunate and blessed to take care of. When you have that trust in your medical provider, these conversations are no-brainers. But yes, it involves us being as transparent as possible. People want transparency and they deserve transparency. And from my end, I'm going to continue to educate people on everything that we can do. But we have to kind of think about not just ourselves, we have to think about others. We've had this kind of sense of like, wow, just me. And that's really how, you could argue how some of the society's gone that way, but we still have to think about the community. And so the reason why I've chosen myself to vaccinate myself is because of my family, to protect my family, to protect my community, to protect my country, to protect the patients that I serve. And so we have to have that mindset. Maybe not everybody has that mindset, but when you have a great relationship with your medical doctor, you can have that mindset. Some of the examples that I do, since we haven't yet vaccinated the patients in our practice, because only right now we're still in the 1A phase. So really it's just healthcare workers, and then residents of long-term care facilities right now. But the 1B phase was voted on earlier this week by the Advisory Committee on Immunization Practices that advises the CDC. And they voted to some of the parameters to start phase 1B of the vaccination program, which should hopefully start early next year. And that is certainly first responders, police officers, firefighters, EMTs. You're looking at essential workers as well too, and then you're looking at people 75 and older. And so you're going to start seeing a little bit more of a broader kind of extension of the vaccine program. But this is as I called it on social media, people that found me on www.drmarcos.com, they know that I called it the greatest American immunization effort. This is truly the greatest and most historic effort we've done in our lives.
Yeah, no, it's absolutely huge, and it's multifaceted. I have two other questions before we pivot that I'd be interested in hearing about, and I hope our viewers would too. So we've heard, of course, that the two main manufacturers of this are Pfizer, Moderna. Those are the ones that have been approved. We all like to comparison shop. Is there really any functional difference between the two in terms of what it will do for you, or is it kind of just two different ways of getting to the same place, and they're both basically equivalent?
So great question. There's been no head-to-head data between the Pfizer versus the Moderna, but when you look at the studies themselves as a single product, both vaccines are mRNA vaccines, and both of them have roughly a 95% efficacy rate in reducing your chances of getting COVID-19. And so when you think about that kind of robust data, now that's after the second shot. It probably happens several weeks after the second shot to get that true antibody buildup. And by the reason why you're seeing that most robust reduction is because on the second shot, what's in the vaccine itself is called an adjuvant. And adjuvants help. It's a chemical that helps promote a much more robust immune response. Let's look at the Pfizer vaccine, for example. After the first vaccine, roughly about 2 weeks or so later, when you build up antibodies, you have roughly about a 50% reduction rate in getting COVID-19. And then when you get that second shot, that's the one that confers that 95% reduction. And so you really want to boost that immune system. So totally from start time to end time, if you're looking at a period of about 6 weeks or so to get full protection from from the vaccine itself against the virus. Now, the vaccines, either that or Moderna, have not necessarily shown that you cannot transmit the virus to somebody else, but it's reducing your risk of getting it. As far as head-to-head, as far as just comparisons, the major difference is storage. And the storage capacity for Pfizer has to be at extremely cold, minus 70 degrees Celsius. Now, what is that in Fahrenheit? We'll just do a simple conversion on your metrics app. and then of course the Moderna vaccine is stored at minus 20 degrees. Now, once you get those out of the freezer, yes, you have a finite amount of time that the vaccine could be in a refrigerator before it's rendered useless. And so the logistics of this is one of the most difficult challenges, but from an efficacy standpoint, no major difference. Only one, I'll say one other thing about the difference is just the timing. The Pfizer vaccine, the second shot is at 3 weeks, and the Moderna vaccine, the second shot is at 4 weeks after the first shot.
All right, marvelous. Well, one last question on COVID vaccines, and then we'll move on. So you mentioned this during your response about still about being a carrier, potentially being able to still infect other people. Obviously 95% isn't 100%, but are you capable still of transmitting the virus to others, even if you don't have an active infection? If, say, it's gotten into you, but you've got the antibodies, your body can find it off, you're going to be okay. Is it really, if you're not positive, you don't have to worry about it, particularly if you've been vaccinated?
So I think that's where we're still trying to learn more. We don't know if somebody who has been vaccinated, if they're still harboring maybe some virus in their body to then pass on to somebody else. This is why mitigation strategies must continue. I'll say it again. This is why mitigation strategies must continue. Wear a mask, wash your hands, watch your distance. We're going to have to stay on these mitigation strategies until every single last American who wants the vaccine gets it. So you're looking at, yes, we're looking into late 2021, although the Secretary of the Health and Human Services came out yesterday after the government has secured 100 million more doses of the Pfizer vaccine, that they're hoping that every single American who wants the vaccine can be vaccinated by the end of June or July 2021. But even after that, it's going to be hard since we've been conditioned to wearing our masks and stuff. I don't think somebody's just taking off the mask right away in the towards the end of summer 2021. I think a lot of this stuff is kind of here to stay. We've been conditioned. It's like the Pavlov's dog experiment.
Yeah. So we still need to be careful. We need to keep every layer essentially brings you further away from getting infected, and we're not dropping them yet until we see these case rates drop.
Absolutely. You hit the head on that. We need to see case rates drop. We need to get down to like New Zealand levels, where as a country, it's amazing what New Zealand has done. And you have to kind of use them as kind of the poster child on proper public health strategies and initiatives. I mean, the case count is extremely low, according to Johns Hopkins University, which is kind of the quintessential global coronavirus tracker leader. New Zealand has under 3,000 total confirmed cases of COVID-19, and the number of deaths in New Zealand is in just the double digits. And so, you're just thinking about the amazing public buy-in, but the infrastructure that was set by leadership and healthcare advocates and public health officials to really make sure that this virus does not get the upper hand. Contrast that, yesterday, of course, Antarctica became the last place on Earth to actually have confirmed COVID-19. So all 7 continents are now confirmed with COVID-19, and that was in a group of Navy people from Chile.
Oh, all right. Yeah. There went my escape hatch. I was, I was thinking of, just heading down there and
they just bundle up and everything. But now it's
going to be a while. While till I get my name called. But well, thank you for that information.
You bet. My pleasure.
It's so important, particularly in today's news cycle and structure, and post-truth and fake news and everything else that's going around, to get good, solid information, particularly on something that's as important as this. So thank you for that.
My pleasure.
I'm going to pivot us a little bit to the doctor's office, to the physician, the internal medicine, to the family medicine office, to general PCP. And I want to ask you a question about how we interact with our doctors. So I'm an addiction specialist personally, and obviously I also do general work. And something that I encounter a lot when I'm working with patients is I might be working with a new patient, and it might actually be very useful for them to communicate with their doctor that they have an addiction, that maybe there's a medication that could be helpful, because we of course have medications for alcohol use disorder and opioid use disorder, or there might even be other health related implications from what they're doing. But they feel like they can't tell their doctor about their drug use or their alcohol use because they're going to be judged, either judged harshly or treated differently. And I just want to get your take. Do doctors judge people like that? Like what goes through your minds? How does that process work?
Yeah, I'll be honest, that's a great question. And I have to kind of pivot as my approach. We all have, probably to agree, some degree of unconscious bias. And we need to just realize that we need to take an opportunity to listen to our patients. I think this comes back down to the doctor-patient relationship and the trust factor. We know that healthcare can be intimidating. And in honesty, when people might only have a short amount of time with their doctor, they may not be able to kind of break down some of the defenses that we put up because, the doctor may be in a rush to get to the next patient, or, you might only be able to talk about one or two maybe concerns. So it's hard to dive down in that. And that's actually why one of the reasons why I changed my clinical practice was I wanted to have more time, not less time, to talk about all aspects of health. And I think when you eliminate time as a barrier, you're able to really kind of get to the issues that truly matter. And having that relationship is so important. So there's nothing more important than the doctor-patient relationship. And I'm very blessed to be in a practice model where I can spend almost essentially as much time as I want with people to really get through the issues. So that being said, I think if you have that good relationship, you kind of take away the judgmental aspects. On the flip side, as a physician, I want to make sure that people have the best resources possible, and part of that is honesty. And so I hope that my patients are honest with me, because I'm going to always be brutally honest with them. And I think when you have that kind of understanding, I think being judgmental becomes less of an issue.
Yeah. So just internally though, because this is what I hear. So like say there's someone you've been working with for years, you have an established relationship, a good rapport. They come in one day and they tell you that actually, they've been drinking, like 8-10 beers a night, and they think that they've got a drinking problem. Does that change your opinion of them in any way?
So that is a great question. And for some people, the answer might be yes, because they might have had this relationship for a long time and they see a pivot and they never would have been told that before. I think it comes back to just you being honest with your patients, me as a physician, and honest with my patients, and I hope that they're honest with me. I still think that the goal, the treatment is the bigger issue there. And if somebody does admit to me that they've been engaging in some sort of behavior that's risky, it's important for us to, in a very non-judgmental way, to really understand maybe why they've gone into that. What are some of the factors that led them to that behavior? But then talk about solutions and go from there. And some people may think
you're not disappointed in them in any way. You're not let down. You're not disappointed. You're not personally offended that they didn't tell you sooner. Nothing like that.
Oh my gosh, you're absolutely right. And you can always think about opportunities that you could have said, like, wow, maybe if I would have, as a doc, maybe if I would have asked them this the last time they saw me, maybe we could have made an intervention. The challenge is when you see people with addiction and some of the metabolics change, some of the symptoms become more pronounced, and you do think of it, because I think we're always human, and that we kind of say, I wish I did this, I wish I did that, because that's, we're problem solvers as clinicians. We're investigative, we're like an investigative journalist.
Yeah.
And so you think about it's hard to not think about the what if. I could have intervened sooner before the liver became into a bad state of cirrhosis, for example, or when you see numbers on metabolic studies, or you see other kind of sequelae of chronic abuse, you always wish that too. So it's a tough scenario, and I think you have to kind of take it on a case-by-case basis.
What I'm hearing from you almost is like almost that you're confused at the idea that you or another physician might even react poorly to that information. Like you just wanted to help. You just want to be able to
help.
get in there sooner. It's not like you're judging them or you feel personally offended in any way. And that's the sort of thing. And I appreciate that validation, because oftentimes that's what I tell my patients, that no, they're not going to be offended. You're not going to like lose your rapport with them. They're just going to be glad you told them. So nothing.
Yes.
Yeah. So honestly, it's so follow-up question though, because I've heard actually the other side of this a couple of times too, where people have disclosed and they feel like they've been treated poorly for it in some way. And some of that might just be their own perception, but who knows, maybe there actually are physicians, particularly those who don't have the best bedside manner, who do respond poorly to hearing this. Maybe they feel like they've invested a lot of time and effort into helping someone, and it seems like that's been wasted in some way. I don't know. I don't want to speculate there, but if you are a patient and you feel like that relationship and that trust is being fractured, what would you recommend? Should they be talking to their physician about that? Like say, hey, like this really hurt my feelings, or I feel offended by this. Is that, how would you handle that interaction from the patient side?
So you hit up on a very good issue, because patients do view their physicians as an authority figure. And so if the relationship is fractured in any way, that can have some really downstream implications, especially from a trust standpoint. I think that's where us as clinicians need to take the time to hear people. I mean, that's one of the biggest reason. I mean, I go back to what I said earlier. The doctor-patient relationship is so important, and if there's any barriers that don't optimize a relationship, then we're not dealing with a full deck. And so I think for me, if I had the patient like that, we have to take the time to understand each other. My goal is still the same: is to help them, give them the resources that they need to be successful in their lives and in their health. And the old saying, as you know, Aaron, your health is your wealth. But this always goes back to the stigmas that are out there. We have to be more comfortable and not mess up the physicians themselves may have their own insecurities about talking about these complex issues. So we have to be comfortable with ourselves to intervene. And if the physician, him or herself, is not comfortable talking about an addiction, there goes the doctor-patient relationship, because then the patient might say, I'm reaching out to you as a figure of authority and knowledge, and you may not know how to help me. So I think it's coming back to our own insecurities as well, too. On the flip side, from a patient standpoint, there may be some insecurities as well, too, to be able to bring that up. So we just have to have better dialogue and just try to do better.
Yeah, well, I think so. I really like your point about the fact that patients oftentimes view physicians as authority figures. At the end of the day, this is actually a partnership, and you're all just people. And just like anyone else in your life, if you feel like you don't have trust in a relationship, or you feel like you're being disrespected, that's a problem. You don't have to just accept it. You don't have to. You can talk about it. You can have a respectful dialogue. And if it doesn't seem to be going anywhere, then potentially move on.
Let me ask you a question. I'm gonna flip the script on you, my friend. Because I think you hit the head on the nail, where it's like, okay, if you're a patient and you're not getting it from your doctor, does a patient have to be stuck with their physician?
Yeah, well, and actually, I was going to surprise you with an extra question about exactly.
Nice. We're asking each other questions. I love it.
I'm going to take questions from you. I'm the host of the show.
I know, it's awesome.
But yeah, no, I'm firmly of the belief that we need to remember that although there are some of these structures and expectancies around, like the same thing works with me as a therapist. I think sometimes people, particularly if they're new to a therapeutic relationship, or if, say, you've been in a relationship with physicians where they know what's best, and they're in charge, and you do what they say, or I guess you don't, and then you just kind of avoid them. But whatever it is, the idea that there can be a dialogue, or that you're not up on a pedestal, sometimes can be a challenging shift. But at the end of the day, they're paying us for a service, or their insurance is paying us for a service. We're just like someone coming and working on your house or on an appliance in a way, in that respect. And so if we're not treating you with respect, you don't deserve to give us your business, in my opinion. Like that's kind of how I would look at it. But to that end, I did actually want to surprise you with a question that's exactly on this topic about how you pick PCPs, because I actually, and this is me being selfish again a bit, viewers may not be aware, I used to be working at Linden Oaks, down right around where Dr. Gomez is in Naperville. I actually live up in the northwest suburbs of Chicago. And so I need a new PCP. I am in the market for a new PCP. I have never had any idea how to find a good one, because basically generally most of the time people are booked, they're not even open. Even if they are, like, how do you find, like, you go to the website and it's just like, this is where they got their MD or DO ages ago, for whatever that means. It's very hard to actually make some sort of intelligent choice about who you work with. So from your perspective, how should someone like me pick a primary care provider? What should we be looking for, and how do we find that information?
What I kind of chuckled a little bit in the sense that you go to a website of a health system and it's dull. Let's be honest, it's stale, and that is the challenge because people want to connect right now. We're in a digital age, of course. Everybody's on their phone doing this kind of stuff. So if your potential physician is not in your search and how you search things, that's a problem. If there's not any, the thing for me is I've put myself out there. People know that they follow me, and so people can find so many ways to learn about me and to see me as a person, but also to see me as a professional. It's hard for physicians to take that leap. Some docs have been very good at doing that and to put themselves out there in the public sphere to do things like what we're doing today. That might be a way to have people, as they're searching on their phones and trying to look at videos of docs, and that might give them a more of an insight. But, the old ways of how you kind of found people, well, I'll tell you what, the old ways how you found docs was looking in the yellow pages a long time ago, or you got it from a friend of a friend, and who's your doc? Right now, docs seem to be out there to attract people. The challenge is this: because of the big burden on primary care right now, even if you do find a doc, it may be very difficult to see that doc in a timely manner, and really to spend the time that you want with a doc. The market's changed, medicine has changed, and most primary care, there's a strain on primary care for physicians, and most primary care physicians see somewhere about 18 to 22 patients a day. They may only have 8 to 10 minutes per patient, and so it's hard to not only see somebody as a new patient, you as a new patient, and find a doc that's got the time, but these docs may also be booked out for several months.
Yeah.
So the system has become an issue, has become a barrier, and then the way how traditional primary care has happened becomes another barrier into getting timely care. That's why, again, you're seeing a big push towards concierge medicine. And there is a national movement towards it, certainly during the time of the pandemic. Actually, as people have been introspective and reflect on their own health, they've been looking for more personal relationships and how to develop that versus impersonal relationships. And so I'm not advocating right now for people to say, oh my gosh, I got to choose a concierge primary care physician. But when you do your searches, try to do the best research as you can. Yes, the education is there, but you can assume that everybody's got more or less the same education. They graduated from medical school in this year. They did their residency at this program. There's a lot of parity, but it's the little things that might connect people more. So docs that put themselves out there, I think that's great. Put yourself out there. Have your health system put you out there and be an advocate for you. That's how patients should really try to find their doctors.
Yeah. So from our point of view, right? Because it's hard, like you were saying, these websites are dry and it's difficult to know. Like, would it be recommended or appropriate? Like, could you call a practice and ask someone about, like, if it's personality factors? I mean, so we learn in healthcare, right, that the consumer now, we expect clinical excellence, right? We're not assuming that we're going to see someone who doesn't know what we're doing. That's
exactly.
Like the baseline, and then after that. That's really where quality differentiates itself and how people choose where they go. Given all of these challenges and barriers to finding out personal information about physicians, is it a crapshoot? Like, do we as patients kind of have to, like, call up a practice, say, like, who's accepting patients, and they're like, well, there's these two people, and you just kind of pick one out of a hat and see if it fits. Is there something more that we could do?
It's tough because that is the experience by many consumers right now, as there have been more introspective during this last 9 months of a pandemic. Like, okay, I need to really get my physical. I've had a physical in 5 years. I need to find somebody. I want somebody who's young, and then they go on a website for a health system that might be near them, and there's 100 docs to choose from. How do you differentiate that? And then you can filter, of course, by male, female, whatever, or location, but then you filter all that stuff and you still have 25 docs to choose from. And so that's where, health systems have tried to do their fair share of getting videos online that people can look at, 2-minute blurbs about this doctor. But that may not be enough to make that thing. One of the things that we do in my current practice is we do what's called a meet and greet. Now, some physicians' offices do that, where you maybe sit down with the doctor for 15, 20 minutes. Now, maybe more done virtually through video. You can do that now because we're in the middle of the pandemic. But there may be opportunities where a practice might offer a meet and greet so you can kind of understand the doc. But that might be the exception and not the rule. And so, but those are some ways to be innovative from a physician standpoint to say, okay, how can you connect with somebody? So maybe people that are out there that look for a doc, maybe the first thing to say is, does this doctor do a meet and greet? Maybe I can find out more. I saw their 2-minute video. I was intrigued by a few of their words. Let me contact that office. Maybe they do a meet and greet for 15, 20 minutes. Now, yes, 15, 20 minutes may not be enough time to really kind of understand somebody's, what they're all about, but it's better than nothing.
I love that tip. I will use that. I'm not lying. I need a new PCP. So meet and greet. All right.
Well, I'm open, brother, but we'll talk offline about that one.
Yeah. Well, I really appreciate you bringing these thoughts about best practice in. And I'm going to highlight, thank you for the comment from Brett. Brett has joined us today. He's the executive director over at the Edward Foundation. And he's giving you a shout out for the good information that you're providing about how to find a new primary care doc. It's something that's it's super challenging, and it's something where we don't want to waste our time or have to tell our story a bunch of times or fill out paperwork. And so taking some of the guesswork out of that, it's fantastic. I want to quickly also mention for viewers, please feel free to put your comments in here. We'd love to answer questions if you have anything. If you want to go off topic, we could potentially even go off topic, but certainly if it relates to what we're covering today, please feel free to add it in there, and we'll try to answer it. It's not every day you get to talk to someone of Dr. Gomez's caliber. He knows exactly what he's up to, as he has shown us already. But all right, let's go. We've got a couple more topics I want to make sure that we get to before our hour is up. So let's go back to behavioral health and primary care. So we were talking earlier about this idea that sometimes people are hesitant to bring up conditions that they have because they feel like they're going to be judged. And that's one aspect, and it sounds like the quick answer to that is that you really shouldn't be if your physician is acting in an ethical and best practice manner. But the other part of it has to do more just with skill set. And so when we're talking about behavioral health, I think hopefully folks are aware, if you're not, that actually about 80% of all psychiatric meds come out of primary care. So a lot of times your antidepressants, some of your anxiolytics, your anti-anxiety meds, most of that actually, they're not being handled by psychiatrists. But I've also, just speaking from personal experience here, I remember be about a decade ago now, I was working in Michigan, and part of an integrated health network, I was seeing a lot of patients, and we were in the same building as a primary care clinic. And so we would very frequently get referrals up from the primary care clinic. We were on the 3rd floor, they were on the 2nd. And I remember we got a lot like this, but this was the most flagrant. I got a referral one time from a doc down on the 2nd floor who said it was for depression. And this gentleman comes in, and within the first 10 minutes, he's talking to me about seeing ghosts and then also having nightmares and flashbacks about his wife's death. So we're talking like florid hallucinations and psychosis, along with pretty clear PTSD, and it just was not identified in primary care. And part of what made me wonder is how do you reconcile gaps potentially in training versus what we as patients feel comfortable bringing in. So I guess I'm rambling a little bit. Here's my question. What should we feel comfortable talking to our primary care physician about in terms of behavioral health? And is there really anything that should be off limits, or that we should maybe just go to a psychiatrist instead?
Well, you bring up a great question. And I love the statistic that you mentioned. It is true. 80% of prescriptions related to mental health, depression, and anxiety, in all honesty, come out of the primary care office. The challenge is we weren't really trained to handle those kind of patients. I'll be honest, my training in mental health was very limited as part of medical school. You have your 3rd year as a medical student, you have a 6-week rotation in psychiatry. Now, I'm dating myself. My 3rd year of medical school was in 2002. And so here we are in 2020, almost 2021. Maybe that's changed. I don't know. But I had a 6-week clerkship with psychiatry. So it's not enough. So the training for primary care physicians to deal with mental health challenges it's not sufficient. Even when we have more of a consciousness on the acceptance of mental health disorders. And so when I got into my clinical practice, I felt very inadequate in my ability to treat depression and to treat and diagnose anxiety or other kind of conditions. You mentioned PTSD. And so there has to be a shift in the education prospect for primary care physicians. That being said, us as clinicians, we are learners. I mean, most of us are lifelong learners. And so, yes, you have to learn how to manage that. A couple other things that are in that question is we have a shortage of primary care physicians. You have people that are looking for primary care physicians. You have a shortage of mental health providers, including psychiatrists. And so to really deal with the mental health challenges that we face as a country, we don't have capacity. And so this comes back to more training for us to be better at it. You mentioned I love how you mentioned that you had a primary care office right on the floor below you. In our model, in my old clinical practice, we actually had an integrative model where we had a mental health provider, a licensed clinical social worker in our model that was in our suite that we can refer patients to right away. It doesn't allow for any prescribing, but it does as a way to help the barrier going on. So there's an opportunity, and I think good health systems will do that. They'll take away the stigma of going to a mental health facility. You're comfortable with your primary care doctor, put the resource right there.
So would you say there's any downside to giving it a shot? I hear you saying, you didn't get, it was a short 6-week rotation and training. To be honest with you, addiction's even worse. I remember I put together a presentation about this. It's been 5 years, so hopefully this has changed a little bit, but the average residency program had, I believe it was 4 hours, not credit, literally 4 hours of addiction training over that entire period of time. And the highest was actually 12 on average, which 12 hours, still not very much. And that was for family medicine. But it's very, you're right. It's very, very minimal for these complex issues like behavioral health, right? So it's such a huge topic. Would you say that there's a downside though? Like say you've got someone who thinks, maybe they think they've got bipolar disorder, or maybe they're really kind of worried. Is there a downside to going to your PCP first, even if they have to refer you out, or should we always be disclosing this and giving it a shot?
Yeah, I think first of all, that's a great question. I think it comes back down to the comfort level and the relationship you have with your doc. For me, yes, have I seen people that are bipolar in my office? And then I refer them, I might start them on something and I kind of think this is bipolar disorder and start them on something and then try to refer them. The answer is yes. And that just comes back to the comfort level. I know there are some of my colleagues that may not be comfortable because of the lack of training, for example, to address those. And the problem is when you have somebody who needs attention, maybe it's not emergent that they have to be hospitalized for acute inpatient treatment for their mental health disorder. But, now you have to put them you get them from the primary care office. By the way, I'm going to paint the perfect scenario. It took them, 6 weeks to see you for a possible mental health disorder because you have no capacity because you're seeing 22 patients a day. And then you see them for a 10-minute appointment and you say, you know what? I can't deal with this. I don't know how to deal with this. I'm going to refer you to somebody. And then you try to refer them to a mental health practitioner, and it's another 8 to 12 weeks out. So now you have a gap of months to possibly be able to treat somebody with their disorder. And that does no benefit to anyone, the person, the system, you name it, in helping to make these conditions much more manageable.
Yeah. So, it sounds like there might even be some pressure on the provider to give it a shot because, like for most psychiatrists, you're looking out weeks, if not months, and someone really needs some help.
Well, Aaron, I was going to say, think about our patients that they might have inadequacies in their insurance. Think about public aid. And one of the biggest challenges that I had in my old practice was if we had somebody who has the state insurance, who has public aid, the chances of finding them a mental health provider that accepts their insurance it's easier to get a root canal. Let's just be honest.
Yeah.
And so then you have a community that needs people, but then they can't get the services. So it doesn't benefit anybody. It makes the system worse. It makes these challenges worse. And it magnifies the stigma that's associated with mental health.
Absolutely. I mean, that's such a tremendous problem, particularly even just for your basic outpatient therapist. If you're on Medicaid, if you're on public aid in some way, you can't get folks in. And then even worse, the reimbursement rate, honestly, is so low that a lot of therapists choose not to do it, because they don't have to. And so it creates this cycle where people who are already disadvantaged are at a further disadvantage, and then and it's harder for them to actually get back to self-sufficiency.
Yeah.
Potentially off of welfare program.
I think that's why we're seeing a big try to hopefully have a community, a collaborative effort in trying to address a lot of the inadequacies and inefficiencies and the disparities, is the best word, that we have approaching mental health. We're not going to get a solution tomorrow. We need more minds like this. You and I discussing today, but not letting this conversation die today. We have to keep having these conversations about how do you have access and equity regardless of somebody's insurance. And that is the biggest challenge. This health system is not perfect that we have. The disparities have been just magnified during this pandemic. And how do we make it better? You and I don't know. We're not going to solve it today. We need broader thought and insight, but also actionable steps. And how do we do it?
Yeah, well, I mean, this is a big political question, I think, in terms of how do you tackle this issue. I know my perspective on it is that just from a financial standpoint, it is a win to work in prevention and anything outpatient, right? Like,
oh my God, yes.
Yeah, I mean, like if you've got someone who's maybe they're not working because of their depression, and you can get them through seeing an outpatient therapist, not having a psychiatric inpatient stay, not going to the ED, being gainfully employed, paying taxes. I mean, not only does their life improve, but even just if you're looking at it from like a budget management perspective, from a state or a federal level, I mean, I still think it's a net game in investing in that. But it's tough. It's just so tough to get the movement.
Well, you think about Aaron, I'll piggyback on that one. I love what you just said. It's hard to get that kind of movement. And then you look about the more broader implications when we think about me. As you know me, I'm a hashtag lifestyle medicine physician. And when I think about the broader implications on somebody's longevity, their vitality, their quality of life, and getting to achieving broader health goals, we still know this, the number one cause of death right now actually might be COVID. I know it was several weeks ago where COVID actually surpassed heart disease as the number one death in this country. And so when you think about outside of a COVID pandemic that's going on, when you think about heart disease and cancer being the number one and number two deaths in this country, we can't even talk about that kind of stuff if we're not, or we can't even talk about how to prevent the top two causes if we're not addressing the person from a holistic standpoint.
Yeah. All right. Well, we've got a question for you about preventing veteran suicide from Jennifer. So she asks, there are many ways that a primary care physician can prevent veteran suicide. How can we in the veteran mental health community and the military community help civilian primary care physicians to learn about how to engage with veterans to accurately assess their needs for mental health referrals? So do you have any experience in that regard that you could learn?
So that is, first of all, great question. And I did do part of my training at the VA hospital from 2004 to 2007. So I'm still dating myself. So I've been out of the mix for a while. But this is where these collaborations need to happen. Collaborations with doctors that take care of veterans throughout the VA system, and then doctors that take care of veterans in the civilian system. And I've been blessed to have in my practice, in my old practice at least, I just started a new practice, but in my old practice at least, where I actually was able to have dialogue with VA physicians and then myself as a civilian physician to treat a veteran and have a collaboration. So now that was kind of me taking the initiative to engage with the VA physician. And luckily the VA hospital that I worked at, a lot of those doctors are still there. And so I've already built those lifelong relationships that I can actually just call somebody up on their phone because I knew them when I was at the VA hospital and easily have a dialogue about a mutual patient. So I kind of consider myself in a blessed position to actually have that dialogue. But I can't say that for every doctor who may not have those kind of resources. So that's a very good question. It's a very tough question, but it goes back again to us, regardless of the patient that we see, veteran or non-veteran, that we have trust in our relationships and also being as transparent with them as possible when we're dealing with mental health disorders.
So this again just gets back to having an open relationship, regardless of what sort of cultural group you're from, veteran or otherwise, being able to interface with the people you're working with. Were there any insights, I guess, just taking it a step further, because I also, I was in the VA system for 3 years myself, throughout my training. From a medical doctor point of view, though, were there any insights that you gained from working with veterans that would be helpful for veterans to know, to share with a physician who maybe didn't have that benefit?
Oh my gosh, the answer is yes. And I just loved my time at the VA hospital, and I was blessed to still have veterans in my practice. Actually, still in my new practice, as I just started about 7 weeks ago. I have been blessed to meet some veterans in my new practice as well, too. First of all, the veteran mindset, when our hardworking men and women served, or are still serving, when you get to meet people that are active service members, but those that I've dealt in primarily a population that formerly served. And so the mindset that they had as servicemen and women in this country, the mindset of what they've done, they do remember their training. And I've got former Marines in my practice, former Green Berets in my practice, and just, former Navy officers in my practice. So I see people that had the mindset on how to navigate and solve problems. The challenge is now when they've made their transition and they are faced, as we get older, as we get older, we face more medical problems, more challenges potentially. And how do you apply that mindset? So I've actually learned a lot from my patients that were former Marines, and how to approach my thinking and my growth as well too. And I'll say this, you and I both know, Aaron, you and I are not finished products. There's always room to learn. And I always try to better myself by having those kind of dialogues. Learning is a two-way street. I learn a lot from my patients as they learn from me. And then I can hopefully pay it forward, those interactions, to the next person that I'm serving.
Mm-hmm. Yeah, I'm always very mindful to not take too many mental shortcuts, too many heuristics when thinking about certain groups of people. Just because people are from a certain cultural group or economic group, or veterans, for example, there might be some trends, there might be some experiences that they may or may not have gone through. But I'm right there with you in terms that we need to be very individual. And we need to not make assumptions, even if we think we're being compassionate, or even if we think we're being sensitive. That's still kind of removing someone's individuality, I think, if you kind of just make them, just a homogenous member of their group.
Right. One of the things I talk about, at least in my new practice, is since I have more time to talk with people, is how do we go from generalizing people in health to have more specificity? It's specificity that's going to allow us to really tailor the strategies that we have for people, again, to live active, healthy, fulfilling lives as much as possible.
Yes. Well, it's actually a great transition into our last topic for today. Before I let you go, which is about how do you actually get people to live active, healthy lives. I know from working with physicians a lot that one of the pet peeves is, like, you talk to someone about making some sort of behavioral lifestyle change, be it like monitoring their blood sugar properly, or diet and exercise for cholesterol, or weight loss, or whatever it is. And then they kind of look at you and nod, and then they don't do it. And then they come back again in however long it is, and nothing's changed. So from your perspective, and again, I know you recently made a transition between working in more of your just very fast-paced clinic life to concierge medicine, which gives you a little more time to work with folks. But particularly for the folks who are in more of that fast-paced environment, which is unfortunately, I think, most of us. How do you, as a physician, what techniques can you use, and what techniques can we use as patients to actually make those changes, rather than have it just be something that you kind of give lip service to, but then don't actually act on?
I think you hit the head on the nail. The things how I approach things is the what, the why, and the how. And so when I sit down with people, I say, what do you want to do? Why do you want to do it? And knowing that why on somebody is so important. Not only does it allow you to understand their perspective, what's important to them, their priorities. Mm-hmm. And so you understand the why on what they're trying to do. And then lastly, once you understand the what they're trying to do, why they're trying to do it, what gives them their passion, what gives them their purpose, then we can start talking about how. But that still is going to take time to have that kind of conversation on a more, to get it from a superficial conversation to a more meaningful conversation. But the what, the why, and the how, if you understand that with people, they're more than likely, you can then you can therefore create a vision that's going to happen. And the most important thing when you talk about sustaining lifestyle behaviors, yes, consistency matters without a doubt. But the important thing as a physician is you got to have a follow-up. And sometimes it might say, because of the traditional fast-paced medicine where the next time the doctor might be able to see you is in 3 months, that might be outside of the window to properly reassess somebody. And so a lot of my files in my practice right now, because I have a smaller population, is I can see somebody in 4 weeks. So a 1 month follow-up, if we're going to talk things. And so you have to have that kind of a consistent follow-up that will allow us to pivot if we need to, change a few things, make some tweaks, and still not lose sight of the broader goal.
Yeah, so it sounds kind of like staying connected and making adjustments, not assuming you can kind of just like set it and forget it, either from the physician side or from the patient side.
Yeah, we have so many different things that we're doing. I mean, we're so we're so busy doing a lot of different things with our health. We only get 24 hours a day to try to make it all work. Then it's got to start all over again. And I think when you understand where somebody's coming from, that'll hopefully allow you as the physician, as a treating provider, to really outline a broader strategy. But again, you have to have meaningful goals. Like, we can't say, like, if somebody comes and says, I want to lose 40 pounds, and that's what they want to do. And they say, why I want to do it? Well, I want to, I'm a grandparent. I want to be able to be around long-term for my grandkids. And how, you can't start talking about losing 40 pounds until we figure out how to lose the first pound. And so we have to be realistic in our goals too. And docs need to be able to be comfortable saying that, and that this is going to be a journey, but we're going to keep checking you during the time. We're going to reassess, and we're going to help you to meet your health goals.
Yeah. So the term we use for that on the psychology side are SMART goals.
Yeah, SMART. I've heard that acronym. Yes.
But let's see if I can remember. So we've got S is for specific, M is for measurable, A is for attainable, R is for realistic, and then T is for time limited. Got it. Woo, it was up.
Absolutely. I was thinking about that myself. I'm like, I don't remember those. I remember the acronym, but I don't remember those exact things. So thank you for, again, lifelong learning. We talked about that. And we're doing it right now. I learn something every day. So thank you, my friend, for stimulating my brain.
Oh, absolutely. But like that framework, and feel free, viewers, also to look this up if you're interested. But in terms of actually doing following through with a goal and being able to achieve it, if you set something that is achievable, kind of like Dr. Gomez was saying, like 40 pounds, it's going to be a little while. But if you're shooting for the first one, you know how long you want it to be until you lose it. You really go through that acronym, you have a better chance of actually following through. So we have time. There's one more question that I want to highlight before we wrap things up, because we've just got a couple of minutes left. But we have a question from Teresa. The pandemic has accelerated some changes that were already underway and needed in many fields. What aspects of medicine and healthcare has the pandemic accelerated in a positive way? And what do you see as potential positive changes ahead of us? Ending on a high note. I like it.
Hey, I think about, talk about ending on a high note. I think of it as, again, taking our superficial relationships, our superficial goals, and making them more meaningful and profound. You'll learn a lot about yourself along the way. Again, it's a journey that we're trying to achieve in life. And, again, as you have success in your health, you're more than likely to have more opportunities for success in your life. And it's not until you understand that kind of concept that you can move ahead. We live in a society where we want perfection. We need perfection, but you have to realize we are an imperfect people. And once you realize that, you can start getting out of your own way and striving for just what's important to you, not striving for perfection. And so I think you have to have that kind of mindset to be able to therefore attack the goals that you want to do. Mm-hmm. So I think the positivity has been hopefully a consciousness and awakening of your purpose.
Yeah. Absolutely. On a more superficial level, I think that telehealth has also taken big leaps and bounds.
That's true. Yeah. I like that superficial level. Although I will say this, I've been able to maintain some really good relationships via telehealth. And if you would have asked me, Aaron, pre-pandemic, would I have been that person that would have embraced telehealth? I would have said, no way. And maybe it was the way I was trained, where you always wanted to be in the room with somebody. You wanted to do a proper physical exam and then render a decision. And now I've had to grow myself. So again, this has been an opportunity of growth that people have. I've been more introspective myself in how I want to deal with my own health, but also how do I want to help others deal with their health. So that is certainly, technology has been a gain, and you can maintain vital relationships that can be meaningful via technology.
Yeah, and then meaningful and effective. I'd say as well. I found this very early in the pandemic. I was kind of skeptical as well, like how is this going to work? But I found that telehealth, it does. I mean, certainly, there's a benefit to being in a room with somebody, but there's a lot of really good work and a lot of really really good healing you can do even if you're not.
Hey, amen, brother. There's no doubt the opportunities there. It's just a matter of us going through that, going down that pathway, being intentional and working with the right team. Again, if you're a team of clinicians, if you're not connecting with your doc, again, you have choice. For the most part, most of us have choice. The hard thing is to try to find somebody, but if you keep looking, if you keep asking questions, you will find somebody who you will connect with. I promise you that. But don't give up. If you're not satisfied where you're at, know that you have to serve your best interests as well too. You'll find somebody who will be able to connect with you.
Absolutely. Well, on that positive note, we're going to wrap it up for today. Thank you, Dr. G, for being my first guest on Let's Talk. Thank you, viewers, for tuning in. Dr. G, remind us, what is your new website for your new show?
Absolutely. So, hey, everybody. First of all, Aaron, it's been my pleasure to be part of your show, and congratulations, my friend, for putting yourself out there, but really to help set the record straight and to be a conduit between people and their providers. To talk about some challenging issues, but to do so in a less intimidating kind of way to empower people to live to be the best version of themselves. So I want to thank you for that one. Yes, my website, my new show is called Health 360 with Dr. G. You can check it out at www.health360podcast.com. You can also follow me. You can check me out, www.drmarkgomez.com. Like and subscribe on Facebook, Instagram, everything. You can find me at Health 360 with Dr. G. You can find me as well on my regular at Dr. G. There's so many ways, but just visit the website www.health360podcast.com. And I wish everybody just continued safe blessings during this this holiday season. Be thankful for the people that you have in your life. Tell that person that you love them. They will appreciate it without a doubt. And peace out.
All right. Well, thank you, Dr. Gomez. And thank you again, everybody, for tuning in. We have more episodes of Let's Talk coming up within the next month or two. So if you want to make sure not to miss it, do the same as Mark said, like, subscribe, follow, whatever it is on the platform that you're watching from today to make sure that you don't miss one. And I'll look forward to connecting with you all again very soon. Take care.